Assalamu alaikum. We are going to start today's session on keratoplasty, past, present, and future. I'm going to call upon stage the first presenter, Professor Dr. Sofia Farooq, for the burden of corneal disease and keratoplasty in Pakistan, a nationwide audit. She's not here. Okay, let's wait for her, but we will, in the meantime, we'll move on to the second one. Okay, Dr. Danish Zafar on corneal retrieval, the challenges behind the process. Dr. Danish Zafar.
Assalamu alaikum ji. I'm so sorry you have to bear with my voice. I'm having pharyngitis at moment. I intended to present my presentation at the end of this session because I will be focusing on the corneal retrieval. So, okay, so we will start with the corneal retrieval challenges in the Pakistan. I will be talking about the challenges in the corneal retrieval program in Pakistan, the recent updates, the key challenges, and the strategic solutions. By the way, this is the first picture of keratoplasty in WIOP Medical College, which I performed a few years back. So why the corneal retrieval matters? You will be talking about the different corneal procedure in the upcoming presentation, and then you can see the significance of that why it matters that we should have the corneal tissue for treating the treatable blindness, and approximately 250,000 people in the Pakistan suffer from the corneal diseases leading to blindness at the moment. So, as I said, that most of these corneal blindness is treatable blindness, and we can decrease the social impact of these blind people by offering different procedures, right from the penetrating keratoplasties to the different layer of corneas transplantation. So the current status is that, as I said, that we have almost 250K corneal blind people in our country, and the cornea received annually at moment is less than 1K. So there is backlog of a lot of patients, and currently we can meet the less than 1% of total estimated need. So because of all these things, as you know, that the corneal transplantation at moment is centered in the major cities, and talking about the Hazara and Ayub teaching hospital, that was my motive, because the people living in the Hazara division in small pockets and coming again and again, and for the follow-up, the cost of the procedure increases and the pain for the patients increases. So you should have a multi-centered in your at the national level in the different provinces, which can deal with all that backlog, which is more than 300K at moment. Most of the time nowadays, we are relying on the cornea from the outside of the country. And in our country, the corneal retrieval program is not launched at moment, except for a few examples. I will talk about it later. So what are the core challenges that hinders the local corneal retrieval? Number one, it can be the awareness and knowledge gap, because most of the general public don't have that knowledge why it is important. Then we have the cultural or religious barriers, and misinterpretation of these religious teaching lead to lack of family support. I'm happy that most of the religious scholar at the moment with us, they are talking about approval from the religious point of view for the corneal donation. But not all of them are in favor of corneal donation at moment. Then we are lacking the system and the policies for developing and sustainable programs of the eye banks. And for sustainability, we need legislations, we need fundings from the government. At moment, this is a big challenge. But still, we have a hope of re-arising. And there are some examples like NADRA has included the donor logo in the NIC program. If talking about the KP, the MTRA KP has registered at least 3 hospitals for the corneal retrieval program at the moment. And we have some examples as volunteer, which is giving a hope that at least we have started talking about the corneal retrieval. So we need basically a roadmap for national self-sufficiency program, which include the targeted awareness, which include the multi-platform campaigns involving the religious scholars to address the misconceptions. We need the operational excellence to train our staff for the corneal retrieval. We need the coordinators for the counseling, and we need the rapid response protocol as well. And for that, we need definitely the infrastructure and the policies so that we can carry on with the self-sustainable programs. As I said at the start of my presentation that there is an inspirational case study, I would love to mention Lailpur Eye Trust Hospital, Faisalabad, who are the pioneers of corneal retrieval in the Pakistan, and currently they are the only one who where the corneal retrievals are done on the regular basis. So what they have done, that they have their infrastructure, they have trained their retrieval technicians, ophthalmic surgeons, and they have the counselor which on normal days counsel the people and targeting the hospitals in the local area. So the call to action is that it is basically a collective responsibility. We should start talking about why the corneal retrieval locally is important. And you, at the end of this session, I hope that you will understand why the corneal tissue matters for treating all the corneal blindness diseases. So for the ophthalmologist, we need to work on our staff. We need to have lead the awareness campaigns. We should be the mentor to tell the people why that matters. The hospital administration should be involved and they should prioritize all these things so that we have a corneal banking system, at least 1 or 2 in every province of the Pakistan. And then we need to engage the policy maker to have funds and sustainable programs. And for the public, as I said before, you need to target even the school children and the young generation for the importance of the corneal donation. Thank you so much.
It's a privilege presenting my talk in front of my teachers, Professor Imran Sahaf, and also
procedure by most of the general ophthalmologists. We all are familiar with this procedure, and we all know that corneal transplantation is one of the commonest performed transplant procedure because of its ocular immune privilege. The first one was performed in 1905, and since then we have come a long way. By penetrating, we means to replace all layers, and by lamellar, we means to replace some of the layers, and they will be discussed by the colleagues who are going to follow me in their presentations. These are some of the indications, and among the corneal causes, keratoconus and corneal dystrophies are the top, but bullous keratopathy is also becoming a popular indications for keratoplasty. We all are familiar with dealing corneal ulcers and fungal ulcers, and if we have the grafts available, then the management can be a game changer. So surgical technique involves preoperative evaluation, which involves all this, but the most important thing I want to stress upon is the use of B-scan and biometry. Sometimes when we remove the scar, there is a cataract there, and if our biometry is not there, so we are not able to put an implant. So it's better to perform a biometry either of the same eye or of the other eye. as well as anterior segment OCT, which can then define the relationship with the underlying structures. IOP control is very important, so per-operatively and before that mannitol should be given, and pupil dilation all depends on whether we are going to do a triple procedure or a single penetrating keratoplasty. These are some of the surgical steps. When most important is selection of the graft size, and then comes the trephination. The first trephination done is that of the donor, and then comes the recipient. Femtolaser is also used for trephination, and recently we started doing that as well. So the graft size depends on the pathology, but the most important message here is that there has to be a 0.25 discrepancy for a proper fit. So first we do a donor, and then comes the host trephination by different kind of trephines, and then we easily cut it with scissors, which I'm going to show in a video then. And a triple procedure, in the morning a video was shown, triple, in which we can also remove cataract and put an implant. So, nahi wapas. Excuse me. Video chalani hai. Yes. So, trephination of the donor tissue is done first. A Teflon block, endothelium side up, viscoelastic being placed, and then you can do trephination. Put it safe, and you can put a viscoelastic on it then. You can do it with femtolaser, and this is the one which is being performed now. That gives a very good cut. But since it's a private sector procedure, so that adds up more to the cost of surgery. So the host trephination can be done by different kinds of trephines. There can be vacuum trephines, adjustable depth trephines, and there can be manual and disposable trephines, which are commonly used in our hospitals. They are different kind of trephines. And then you use corneal scissors to complete the cut. Now, host trephination can also be done by the use of a femtolaser, and you select a graft size, and then a very clean cut. So then comes the suturing technique. So the first 4 sutures are very important. That is the fixation sutures. And then the rest of the suturing, you can use continuous and interrupted, both combined, or you can use interrupted alone. So for sutures, even markers are available, and you can use that for proper alignment. Remember that one suture can induce astigmatism up to 1 to 3 diopter. So this is the triple procedure, in which there is a cataract, you deal with it there. You can put a vision blue in this case, and after hydrodissection, the nucleus is delivered, and sometimes the posterior capsule there can be a very positive vitreous pressure, so with mannitol use can help a lot in such cases. So there's a long list of complications for penetrating keratoplasties. Per-op, post-op, and we have to be vigilant for a very long time to look after these patients. So when we say anatomical success, we mean we have a clear graft which is avascular, and there are good suture alignment there, and there should be no rejection there, endothelial count should be enough for the detergents. So that means anatomical success. And there should be no such complications which I have mentioned. That will ensure a good anatomical success. For a good physiological success, it means very good useful vision after the procedure. These factors have to be addressed or they should be absent, like irregular astigmatism, cataract progression, macular diseases, and optic nerve diseases. These all factors contribute to physiological success. Management of post-penetrating keratoplasty astigmatism is the most important thing. In the early time, you can manipulate with the sutures. You can either remove or loosen the tight suture on the steeper meridian, and as I said, it can reduce the astigmatism or induce the astigmatism by 1 to 3 diopter. And all is done by topograded. Astigmatism, once when you remove the suture, how to deal with that? So the non-surgical options can be specs and contacts, as well as the corneal procedures, which can be paired arcuate incision, where you have to reduce astigmatism in the steeper meridian. That can be done manually with diamond knives or femtolaser assisted. Again, another use of femtolaser here. So sometimes you have to combine it with compression sutures. So these are the procedures which we do when, okay, corneal wedge resection with very high astigmatism, more than 10 diopter. And the other thing is, you can also do a topography guided PRK or femtolasic in these residual errors, provided there is adequate stromal thickness and there is a stable endothelium. You can combine it with corneal rings as well to deal with these kind of astigmatism. That is after removal of sutures. Greer grafting is an option when the astigmatism is more than 15. It is an irregular graft, it's an ectasic graft, it's a scarred graft. Then you can think about either regrafting or a Boston keratoprosthesis, which my other colleague is going to discuss. So this is just a management plan for different type of astigmatism, pre-op and post-op and so on. So these were some of the patients which we did very recently. And thank you very much. But I would like to thank the donors, because behind every clear cornea lies a silent act of generosity. ये वो अजीम तोहफा है जो जिंदगियों को नई रोशनी देता है, and for which we would be grateful and thankful to our donors. They are the true enablers and the true heroes of sight restored. Thank you very much.
Thank you, madam. Our next presenter is Dr. Zaman Shah. He's going to talk about the evolution of corneal transplantation.
Bismillahirrahmanirrahim. And today's topic is basically the evolution of the corneal transplantation, and we will be starting from the DSEC to DMEC and one of the newly designed procedure by the name of the DRLT, donor to refractive lenticule transplantation, which we have the honor to design a few years back. And hopefully we will show a video of the DRLT with as well. Now, if you look at in the selective lamellar corneal transplantation procedure, this is in alphabet soup, where you got the full thickness anterior lamellar keratoplasty and a number of the endothelial keratoplasty, right? Now, in endothelial keratoplasty, basically this is a revolution in the history of the corneal transplantation, where we got a various posterior and anterior lamellar corneal transplant procedure. Among these is the DSEC, decimate stripping automated endothelial keratoplasty, for which we need a donor microkeratome. Again, it is a sutureless procedure. We need a small incision. It's a very close procedure, and there is a minimal ocular surface disturbance and minimal refractive change. And so less tissue is transplanted in this procedure, so less chance of the rejection. Now, this is one of the paper in American Journal of Ophthalmology. What are the indication for the DSEC procedure? The FOX is the most common one. Pseudophakic bullous keratopathy, repeat graft, other form of the endothelial decompensation. Now, what are the advantage of the DSEC procedure? It is a small incision, close eye surgical procedure. There is a greater wound strength, large diameter graft than the PK, so more endothelium they are transplanted. So again, no ocular surface disturbance. It is basically a faster visual recovery, and there is a relative ease of the repeat transplant. Now, this is the disadvantage. The donor dislocation is one of the major disadvantage. Damage to the endothelium again, and it's got a very steep learning curve. And of course, the other things as well. Another modern procedure is the DMEC, disseminate membrane endothelial keratoplasty. The difference between the two is that in DSEC there is part of the posterior corneal stroma, but in DMEC only the disseminate in the endothelium, right? So how we size, which size of the donor tissue we select, this is variable. In USA, in most of the center, they select a large diameter graft. Here in Pakistan, most of the DMEC surgeon, they select only 7.5 to 7.75 millimeter is the size of the graft. This is how we sizing the graft size. There is some problems for the larger graft and for the smaller graft. Basically, in problems of the larger graft is that it can be difficult to unfold, especially if the anterior chamber is shallow, and we may have the central detachment. Larger graft may also overlap the disseminator rexus edges. That's why detachment is more common. This is the previous PK. We can also go for DMEC in the previous PK, but the size, suppose if the size is 8 millimeter, so we keep the size of the DMEC a bit smaller, right? So that it should not override the edges of the previous PK. This is again, we are talking about the sizing of the graft and how we prepare the graft. We can prepare the graft by itself, and we can also get the donor DMEC tissue already prepared. No, graft injection has got their own methods how to inject the graft. And this is the various configuration of the graft where you can get, this is basically the tricone head, and this is the self stable graft. We can't discuss more this in detail, but the new era is that of the donor to refractive lenticule transplantation. This I will show you a small video. This actually the new design, we did this a few years back, and this is only at the moment available in Pakistan, and where we utilize the donor tissue. The donor is from the small lenticule, or the graft is obtained from the globe. So the basic aim of this DRLT procedure is to implant a negative meniscus shaped lenticule and to reduce the topostigmatism and the CAMX. This is the protocol I have designed for patient who is undergoing for the DRLT. And DRLT is performed only in individual with advanced keratoconus. Actually, what happened that keratoconus cornea, we feel that it is an abnormal cornea. Keratoconus cornea is not abnormal cornea, right? There could be some abnormality in the cornea. So why to replace the keratoconus cornea by 78-year-old donor cornea? We applied a number of the sutures. Patients don't like suture. Surgeons don't want rejection. So these both problems, they are not there in the DRLT. This is some of the protocol, who is the good candidate and where it is contraindicated. At the moment, we have the honor to design 7 different DRLT version, 7 different procedure. Now we are at the moment doing first version, which is basically we are using the smile derived lenticule. In version 2, we are utilizing the globe derived lenticule. So the 3rd version has got again 3 types, and these all types, they are there in the DRLT book. Recently, we have the honor in the last 6 months. I have written a book on DRLT. It contains 6 chapters and 250 pages book. And recently, we have published a paper in the Cornea Open in USA on the smile derived tissue. Soon, this book will publish in Springer, and this will be available around the world in all the libraries, including our country. This is, we have made some of the nomograms. The good thing is that we somebody should attend this presentation here with me in the cornea session, but this is the various cone size, how much we should keep the diameter of the donut lenticule, and which pocket size we need. We need VisuMax machines or Zimmer Z8. with these two machines, we can do this procedure. All the 7 version can be performed only with the VisuMax in the Zimmer Z8. There is no manual. This is the beautiful video, and this is the second version. Actually, we order for whole group, right? This is the parameter which is the whole group. Look at this. We are basically, all of us, they are laymen, right? If you look at this photographs, which one looks beautiful in a layman thinking? Look at the first one is the posterior T. This is the day one, quite beautiful picture, right? This is the first day. In the second one, if you look at the cares, right, a big tissue is there. In cares, this is a visible tissue. The patient don't like any visible tissue in the cornea. This is a bunch of the tissue. The patient hate it because this may result severe photophobia. The patient don't want 6:6 vision in the presence of the photophobia. The patient wants 6:36 vision, which is a good quality, than the 6:6 vision, which is a poor quality. Look at the other picture, intakes. It's quite visible marking. And if you look at the post-op day, the first day, the one picture which is good, that is the post-DLT day one. If you look at this case where we have operated on the left eye, this is the pre-op pentacam, this is the post-op pentacam, and look at the results. In the pre-op, look at the K1, K2, significantly high, Look at the post-op, it comes to almost near to normal. So we keep the optical zone in the normal level. Look at the two-phase stigmatism, 6.3 comes to 2.1, and similarly, we want to keep it in a negative meniscus. So if you look at the thinnest location, almost remain the same. Of course, the visual acuity in this patient was 636 in the glasses, but it is without glasses 6/9. Most of these patients after the DLT, they are happy with the glasses, right? And look at the same patient in the first of day 1 and day after 43. You will not be able to locate the DRLT tissue because there is biological integration. In the rest of the procedure, there is no biological integration, that is mechanical only. By mechanical only, we got a table, not here, but in the conversation, but they are basically mechanical only. Look at the anterior segment OCT. The first one is taken on the non-donor zone, where you got the complete ring. In the second one, there is a defects in the center, which is telling about that it is the anterior segment OCT on the donor zone. This is the second patient. This is the pre-op right eye. This is the post-op after 26 days. This is after 67 days. This is the difference map. And look at this table. Both the K1, K2, 52, 58 comes to 43, 47, comes in the normal range. So this gives you a good optical zone in the normal range. Look at this picture. This is post-op day 13, where you can see the visible tissue. In the next one, hardly visible, and in the third one, after 47 days, you will not be able to locate the tissue even in the slit lamp. This is another eye of the same patient, because this patient was very much happy, so we did the procedure after a month. This is after a month. This is the difference map, and you can see the K1, K2 decreased by -10, -11, so significant reduction. So in conclusion, this needs an allogenic tissue. There is no peribulbar or general anesthesia. We need only a topical anesthesia. This is biocompatible tissue. There is a good corneal integration. This tissue is easily available. This procedure is not economical because it costs around $250. This is the running cost because we are using the WIOP docking system, which is a bit expensive. So, thank you very much. While we got other design like was third version 4, 5, 6, and 7, we can do the procedure even if the thickness is less than 350. In other procedure, there is cone augmentation, while in this procedure, there is no cone augmentation. Like suppose the third version is basically designed in a manner that if I ate 160 micron thickness of the total donut size, donut thickness, and at the same time, if the thickness is less than 350, I want to augment the cone as well, then I put another small 4 size millimeter lenticule in the center of the cone, the thickness of which is around 30 to 35 micron. So I increase the size of the is again the central negative meniscus maintenance, which is we want. Okay?
Have you seen any progression of?
So far, we have done more than 250 cases, and I have published papers in the Crown Open, and we have not seen any of the case of the rejection, as well as the progression.
So any difference between the post CXL eyes?
Actually, we people, they are doing the CXL at the first step, but usually I advise, and my new recommendation is to go for DRLT procedure first, because CXL will not stop the progression. When you do the DRLT procedure first, you can do the CXL at the first month. Even in the first and second version of the DRLT, one thing that you will say, you will ask again that there is no increase in the thickness of the thinnest location, then how you can perform the CXL when the thickness is low? The answer is basically when you do the procedure, in the first month there is some increase in the thickness of the thinnest location. So that is basically a honeymoon period where you can go for that of the CXL after the DRLT. In the rest of all the procedure, you can do the CXL without any fear, because we also augment the thinnest location. In the version number 6, actually, this we have discussed with you the correction of the anterior keratoconus, but there is no correction of the posterior keratoconus. So for that, I have designed another procedure where we will be implanting double lenticule. The posterior lenticule will be that is from the smile derived, while the anterior lenticule will be derived from the globe.
So very impressive. Thank you very much.
In the morning, I did one presentation, the paradigm shift of the DRLT, and now we have got the part 2 and many more. Thank you.
Thank you, sir. I would like to request Professor Dr. Rehan Moinuddin to please come and talk about DALK mastery, tips and tricks for better outcomes.
It's a pleasure to be part of this event, and thank you for the opportunity. The mastery, I've got it because I think the many best masters are present, so essential tips and tricks for the successful DALK. Right now we have two famous techniques in DALK, which is called as the big bubble technique and the Millis technique. The salient features between them is in DALK we inject the air into the deep stroma, while in Millis we inject the air in the AC. The goal is to achieve the adjustment membrane in DALK, while in Millis you can leave a residual stroma. Visual outcome is, of course, is better in DALK regarding contrast sensitivity and visual acuity. Steep learning curve in DALK as compared to Millis technique, and possible complications in DALK is more, and the conversion rate to PK is more in DALK as compared to Millis. In Millis, you need special instruments just to dissect the cornea, which is called as a Deaver's dissectors. One of them is the straight one, and then again the curved one, just to make the space there, and then you make it a bit easy procedures, but I think people prefer DALK over the Millis. Now, benefits of DALK, everyone knows it. I differentiated in different phase, divided the DALK in different phase 1, phase 2, and phase 3. Benefits, of course, everyone knows, eliminates the risk of endothelial rejection, lowers the rate of graft failure in long term. Structurally, it's a strong globe, and you can put a large diameter grafts. Faster visual rehabilitation, typically has a lower rate of post-operative complications, and shorter duration of steroid therapy. The best candidates, of course, keratoconus patients, post-LASIK ectasia, stromal scars, post-intacs and CXL patients, and corneal dystrophy and degenerations. Now, phase 1, you have meticulous pre-op planning for this one. Slit lamp examination is mandatory, depth of cornea pathology, eyelid examination, surface examination is must. You have to master the pentacam, use thinnest location in best, see a thinnest location in pentacam, and Scheimpflug images. And after that, anterior segment OCT, of course. Always tell the patient to keep the plan B, inform that patient that you might convert this case into PK. Now, you need a rock solid globe to achieve a big bubble, and depth of definition is 70 to 80%. You need a guided trephine and femtosecond laser to reach to 70 to 80%. But in case if you don't have a guided trephine, how you can achieve this 70 to 80%? This is trephine. You can see the hole in the leg of the wheel of trephine. If you turn this trephine to 360 degree, it will give you around 250 micron depth of trephination. So if I divide this trephination in quarters, in 4 quarters, so per quarter it will be 62.5. Okay, let's make it 60 microns. So if your target is 500 microns divided by 60, equal to 8, it means if you do 8 quarter turns, you will achieve 500 microns. Most of the time, you are right in this one. Okay. Phase 2, the holy grail is achieving a big bubble. It's a holy grail, big bubble between the Descemet membrane and the posterior stroma. The needle is very, very specific thing. You should not use any dull thing. Use 27 gauge or 30 gauge air cannula. Anwar, Guider, or Fogla have the pointer dissector. A dull laser, it shed the stromal shedding. What is the sweet point? That you achieve the deepest part of the trifinish. Now, the art of big bubble, the level and the advanced technique that keep the needle bevel down and parallel to the corneal surface, and advances slowly and confidently in the deep stroma until you feel a sliding effect. I'll show you in the video what I mean. Once you have a gliding motion, it means you are in a pre-Descemet area. Okay. At that time, inject the air in the stroma 2 to 5 cc, but don't pump it, because otherwise you will rupture the Descemet. Now, these are 2 pictures. One is my teacher, is Dr. Fogla. He do a partial superficial keratectomy. He decapped the cornea. I don't decap the cornea. I use it with the proper cornea. And then this is the thing which was I was telling you, the gliding motion. This is the resistance you are feeling. Now at the end, you will feel this fraction of seconds, you feel a gliding motion. It means you are in a proper plane. You are in a pre-Descemet area, and this time you can bubble the cornea and achieve the big bubble. The stromal dissection. There is a small bubble test, which is first described by Singaporean surgeons, Mr. Tan and Mr. Prasad, I think. What they do, that they inject small bubbles in the AC before injecting a big bubble. So what it does, that small bubbles go in the periphery, and you confirm, yes, you got the big bubble, right. Now once you have a big bubble, don't rush, okay. Be carefully and open the stroma. I'll show you a small video. This is how you can open it. Don't push too much, okay. And few surgeons, they prefer, once you have a rupture in the stroma, just put a viscoelastic that you have a nice, the Descemet is away from there, and you can cut the stroma. This is one which I was telling you. So once you have a big bubble, then your small bubbles, they go in the periphery. It means you have achieved a good big bubble. Okay, this one you can see here, the small bubbles, they go in the periphery. And once you have a nick in the stroma, this bubble travel and come in the center. Okay. This one, just the residual. You just cut the residual stroma carefully, and you can use here the dissector in the periphery, not to rupture it. This one is bare Descemet right now in front of you. You have seen small bubbles, and of course, you have done everything perfect. And sutures giving you 8 diameter of astigmatism, it's a very bad surgery. So do 4 cardinal the sutures. Use a good diamond. Take a time to make a diamond, and this will give you a precision adjustment and very least astigmatism. Always try to use Maloney ring. In case you don't have a Maloney ring, what you can do, that take a 10 cc syringe and take a segment of around 2 centimeters, and then use it to see your astigmatism. Can you see here? Is it astigmatism? There is an astigmatism or not? There is around 3 diopter astigmatism. You can see it's oblong. It's not very round. So just adjust it. Once you start using Maloney ring, you know what's going on exactly. This is the 4 cardinal sutures. You can see here the diamond. You should have a very nice diamond here, and then 8 interrupted sutures, and here 16 sutures. I usually I don't go for 3-1-1. I always use sliding sutures, so I can manipulate the astigmatism. And thank you very much.
Next, I would like to call upon stage Dr. Sidra Latif for predicting success and failure key indicators for corneal grafts.
Latif, and I'm working as Assistant Professor of Ophthalmology, King Edward Medical University. Today, the topic for my discussion that I was given was that what are the indicators to ensure success when we are doing corneal graftings? First of all, we need to see what we mean when we say that our corneal graft was a successful one. We not only mean some anatomical outcomes, we also mean visual or functional outcomes for that patient. Anatomical outcomes, we want to reinstate the clarity of the cornea like God made it, although we cannot achieve that to that extent, however, we will try. However, anatomical success also counts that we maintain the clarity of that cornea and we do not end up giving more complications to the patient like a phthisis bulbi. So other functional considerations that we need to keep in mind to ensure a corneal graft success is that the patient should have a best corrected visual acuity, which should be good enough. We are not reaching this level of 20/40, which has been identified internationally as a good outcome for the keratoplasties. Also, when we are doing keratoplasties, we need to remember we are doing it in hot patients as well. So in those patients, we need to see that have we relieved the pain of the patient. What you can do to quantify whether your corneal graft was a successful one, you can use a very easy score which can tell you about the clarity of the cornea, the edema of the cornea, and the post-operative vascularization status of the cornea. You can do the vision of the patient and topography. Topography will tell you a lot about how good your surgery was. And in terms of topography, you need to see the Kmax of the patient. But in many patients, even when the Kmax is within acceptable ranges, you may have surface irregularities, which are shown by the surface asymmetricity index. And if that is too much, even then the patient will not have a good enough vision. The proposed classification for post-operative astigmatisms, we have regular and irregular astigmatism. We wish to lie in this category. However, mostly we are lying in the irregular astigmatism categories if our suturing is not good. The difference between a prolate and an oblate astigmatism is in prolate ones we have steeper centers and flatter peripheries, while it is opposite in the oblate ones. The irregular astigmatisms, they are very, really difficult to cater for, like Dr. Sophia already told us about the suture managements and the corneal contact lenses that we can use. We can go for PRKs. However, we should avoid them in the first place if we can. So these are just some of the patients. There you can see the steeper peripheries, the steeper peripheries, and sometimes you can have the steeper centers. How can you ensure that your corneal graft results in a success? There are preoperative, intraoperative, and postoperative considerations. We know our cornea is an immunologically privileged organ. However, when that privilege is lost, it just behaves like a solid organ. For example, just like you're transplanting liver or kidney, and you need to give that much attention to that cornea. How does our cornea lose that immune privilege? Just by having somewhat vascularization over the cornea and somewhat lymphatics into the cornea, and then your immune privilege is gone. How do you lose that? By having inflammation or infection of the globe, or by having glaucoma in that globe, or by having an ocular surface disease. So preoperatively, you need to address all of them. For vascularization, you can do fine needle diathermies, anti-VEGF injections. You need to address stem cell deficiency beforehand by doing simple limbal epithelial transplants. And you need to check whether that patient is a good corneal sensitivity or not. If the patient sensitivity is not good, you will not end up with good results in that patient. And also for hepatic eye disease patients, you need to start that prophylaxis beforehand. You also need to see where your graft tissue is coming from, your donor corneas, where they are coming from, how the processing was done, how it was stored, what was their death to preservation time. And if these things are amiss, you will not end up having the results that you are expecting. You do not only see the endothelial cell count of the grafts anymore, although that's the major thing that we are watching out for. You are doing several other tests like slit lamp biomicroscopy, specular microscopies, and you are looking for polymorphisms and polymagathisms in the endothelial cells. Pleomorphisms mean that the endothelial cells are of very varying shapes instead of the hexagonal ones, and polymagathism means they are very larger cells. All of them show that they are having some trauma to the cornea. The IBank, American Association guidelines, they say that they should have been preserved in an +2 to +8 settings in a refrigerator in an appropriate hypothermic solution like Optisol, and the cell count should be more than 2000, and polymagathism and pleomorphisms should be good. Also, if you want that your cornea results, the grafting results and good quality results, you need to adopt the right type of transplantation for your indication. For example, if you have degenerations which are centered mostly in the anterior part of the corneas, go for lamellar keratoplasties. However, if you have ulcer which penetrated up till the posterior depths, then you have to go for a penetrating grafts. Similarly, an endothelial corneal decompensation should be addressed by using endothelial keratoplasties. If you choose the right type of transplantation for your indication, then you will end up having good results. Intraoperatively, you need to see that your sutures, they should be well centered, they should be radial. Try to pass every suture, extend it and see that it is passing through the center. Radial sutures will result in better results. And you should use good quality instruments and refines to ensure those sharp cuts if you do not have the femtosecond lasers. Your sutures should be equidistant, equal in length, and try to avoid the limbus as much as possible. Bury the knots away from the limbus because the knots are a continuous stimulus for the vessels to grow. You need to ensure the anatomical alignment of your graft and host. In keratoconic corneas, the host is going to be thin, the graft is going to be thick. What you can do, ensure an epithelium to epithelium coaptation, and you will end up having good enough results. Do not go for a small graft or a very large graft. A small graft leads to glaucoma, large graft leads to more rejection. So these are some of the points that you should look for, and that is just the disparity that I have shown, that try to align your epithelium to epithelium. Inside alignment will be managed by the nature. So post-operatively, I already said that if your cornea has already lost that immune privilege, you need to treat it like a solid organ. Topically, you are already starting immunosuppression in all the cases, which will be dexamethasone, and you have to taper it very carefully, very slowly in a prolonged manner, especially in full thickness grafts, in endothelial grafts. However, you can be a little bit relaxed in the lamellar keratoplasties. You can use cyclosporin 5 times a day. Additionally, and systemic, you have to give when you have high risk factors, and that should be 1 milligram per kg per day at least. However, beware of the steroid responders. Suture management, early suture management needs to be done whenever you see that even slightly loose suture, even if does not have debris, please be sure that it will collect that debris and you take that suture out. It's doing more harm than any good. Selective suture removal after 6 to 9 months with the management of the astigmatism. The largest trial that was done to ensure what risk factors are going to harm your corneas or not, that was the collaborative corneal transplantation studies. The non-modifiable risk factors, sadly, in age less than 40, if you are a male or you are having a repeat graft or you're of black race, or you had a chemical burn, you cannot modify these factors. The modifiable factors are that the smokers have a higher risk of transplant rejections. If you have uncontrolled IOP preoperatively and neovascularizations, these are the things that you can modify, and these are the things that a surgeon can modify, ensuring good outcomes for your corneal grafts. So what we indeed want,
Madam,
we
8
want a
minutes.
healthy and a happy graft. And you can do that for that you can easily do by good preoperative optimization, as well as intraoperative good tissue handling and postoperative vigilance. Thank you.
Next, I would like to welcome Dr. Mushtaq Khattak for Boston keratoprosthesis.
Bismillah Rahman Rahim. Thank you, everyone. My presentation is a little bit different. Lot of talk has been done over the penetrating keratoplasty, lamellar keratoplasty, all about the keratoplasty. But when the keratoplasty is not possible, and there are certain conditions where keratoplasty is not possible, or multiple time keratoplasty has been done, then and at the end it's failed. What can be done? Then the thing is Boston keratoprosthesis, a new horizon for end-stage corneal blindness in Pakistan. What is basically Boston keratoplasty? This is a synthetic corneal implant made of optical front plate, back plate, donor corneal graft sandwiched between the two plates. It functions as a permanent clear window that replaces an opaque or damaged cornea. A little bit about the history. In 1960, keratoplasty, Kepro has been started. The concept of Boston keratoplasty was introduced by Dr. Klaus Donman. In 1992, got FDA approval. 2000 to 2020, titanium bake plate was developed, leading to a global use of the device. In 2014, the first successful Kepro surgery was performed in Pakistan at KEC, Hatak Eye Center, which is now Frontier Institute of Ophthalmology, FIO Hospital. Up till 2025, achieved a total of even more than 26 successful surgery of Boston keratoplasty. These are some of our patients, which you can see the Boston keratoplasty. What are the indications? Indications are multiple failed graft. When you have no choice, at the end, you will go for keratoplasty. Chemical, thermal burns. I think these patients are not suitable for penetrating keratoplasty. Autoimmune condition. The most common one is Stevens-Johnson syndrome. So these patients are not suitable for penetrating keratoplasty. And I read, other corneal issue. In the absence of an iris and causes of vascularized cornea, severe dry eyes can complicate corneal health. Kepro can restore vision in these challenging scenarios where traditional methods fail. What is the device design? Device design is PMMA optical stem, donor corneal tissue, titanium bake plate. Previously was used the PMMA plate. There are mainly two types of Kepro. Number one is type 1 keratoplasty and type 2, which have a protruded optical portion, which can be used in cases of severe Stevens-Johnson syndrome or all those cases where cornea is not visible. Then you can protrude it through the lid and they can see it. And even a patient can see 6/6. I have personal observation and personal patients. They can see 6/6 vision. Surgical technique, assembly of Kepro. First, you will do the trephination of recipient and donor tissue. And donor tissue, you will make second trephination in the center with 3 millimeter trephine, which especially come with the Kepro. Suturing donor Kepro complex and bandage contact lens applied. It's so simple, but probably this is the reason a moment before a doctor asked me that we are thinking about the Boston keratoplasty, which is not very viable thing, as like patient immediately get glaucoma, extrusion, infection. But I have personally a very good experience with the Boston keratoplasty. Outcome and complication. The Boston keratoplasty demonstrate high success rate in visual recovery for patients suffering from irreversible corneal blindness. Many patients experience significant improvement in their vision post-surgery, leading to enhanced quality of life. However, there are common risks associated with the procedure, including retroprosthetic membrane, which is most common, which also seen in patient after a year or so, then you can easily do a YAG laser. You can remove it. Glaucoma, yes, this is a very dreaded complication. Glaucoma, then you will treat the glaucoma accordingly. Infection, such eyes usually get infected, so very careful. And extrusion, keratolysis. Careful monitoring and management are essential to mitigate these complications and ensure long-term success. Now I am showing you few cases of Boston keratoplastosis. This is one of our case, a multiple time corneal graft failure, and he has got a very good vision. The surgery, you can see the Boston has been implanted, and he has a very good vision. And still, I think probably this Baba has been implanted 3 years back, and still he is enjoying his vision. Second case, this is a Stevens-Johnson syndrome, and you can see the patient has severe dry eyes, but the patient is enjoying her vision. One another case, this is very interesting case. For the last 7 years, he is blind with both eyes. Due to bomb blast, multiple corneal graft has been done, and he was from Afghanistan. All the patients are consented for video presentation and pictures. So this is, the Baba has been implanted the Boston, and he was surprisingly see 16 vision after hand movement. And you can see, and after multiple corneal graft failure, he is still, this is probably a 2-3 year back patient. And for the last 4 years, he was totally almost hand movement vision. And you can see how he is, means this is how is 1 week after the surgery, and patient view are amazing. This is usually emotional. This is one another case which I have done a week before. And this is Dr. Alia. She is now pediatrician. And she was resident when his father first see her face. And I think after 7 years, he has seen her daughter. And this is a severe Stevens-Johnson syndrome patient. He is running his own private school, and he was so emotional after seeing his Muhammad's son and daughter, Dr. Alia. This is one another case I haven't seen. This is just a first post-op day of a 5-year-old sclerocorneal case. And he is densely amblyopic. I have implanted the Boston keratoplasty, yet have not seen the post-op result. I have called him after a week. So this is what the surgery is going on. This is practically this, if you see it, this is totally sclerocorneal tissue. I was unable even to mark it, where is the cornea. But after removing the scleral tissue, there was a beautiful iris and lens. And I have removed his natural lens because the Boston model was for the pseudophakic patient, or for aphakic patient. So this is...
Sir, time.
My time is, I think, a little bit more. Okay, this is just last case. I'm showing you. This is this patient, this is the trepanation in the center, and this is application of the Boston, and has been implanted, and the lens is removed. And at the end, you can see I have implanted the Boston complex. Sorry? Cost is depending, means the Boston, it's almost $1,500. Yes, in this child I have used the same cornea because it's like sometime I'm using the same cornea and sometime donor cornea. Usually indication is for donor. And you can see his centrally beautifully Boston keratoplasty has been implanted. Yes, but sometimes the cornea is not so good. That's why. So this was the last case. Kipro is a game changer in irreversible corneal blindness, demands careful selection, surgery, and follow-up. FIO is proud to lead this advanced care in Pakistan, from darkness to light, one eye at a time. Thank you. Along with the topical drops. Drops is prophylactically we are starting it. Because this was totally a sclerocorneal state. But this is obvious that the PKP in such cases so much bleeding, as you have seen, the vascularized area. Yeah, this could be an option, but I have selected this patient. This was a one eye case. Yes. Yeah. But you will not leave the patient as such. You will treat the glaucoma alongside the Kipro. Even you can, I'm planning for AGV implant along with the Boston keratoplasty.
First case which you showed, I think that was the one in which the drop was already late. First patient you showed.
Yes. You have also implanted one. This was a 3-time. Patient was treated 2014, and still he has counting finger vision. Disc is totally cupped. I'm seeing the disc, but still for the last 12 years he is enjoying his vision. Even still he is counting finger.
About the infection, glaucoma?
Yeah, the 2 patients I have got the retinal detachment case, and I have done the PPV silicone oil injection. One patient is with the silicone oil, he is counting finger, he is enjoying the vision. And about the infection, yes, the patient got infection. One patient I have got endophthalmitis. Yes.
Glaucoma?
Glaucoma is, you cannot even measure the pressure at this stage. Some topical anti-glaucoma medication we are constantly giving to the patient, because this is the last means when there is all ways are closed, only the one way Boston keratoplasty.
Yeah, that's my concern is for the child. Penetrating keratoplasty was a better option.
But for the child, this was sclerocornea. Even there was mark cornea, so I was unable to even identify exactly where the cornea is. So that's why I have chosen this patient for. He has a very beautiful graft I have done with the Boston, and hopefully he should. This is obvious. The child will be densely amblyop because he is 5-6 years old. But again, he will get some vision. Yes, membrane. The one patient which I have done in 2013-14, he has got twice retroprosthetic membrane, and I have done the YAG laser. Yeah. Yes, YAG laser and do even retina surgery. I have done twice retina surgery in Boston keratoplasty patient.
They are wonderful, wonderful presentations. And this presentation, particularly this one on Boston keratoprosthesis, was quite an eye-opener. Apart from the price, I think it is probably the only option that we can offer. Considering that at our center we are doing a lot of keratoplasties, we do also see patients who have failed keratoplasties, and not once but twice or thrice as well, and they are blind and they have no other option. So I think this is one of the things that can be offered to those patients. But apart from the steep $1,500, how much would that be in PKR? Just I think it will be like 4 lakh. 4 lakh?
Yeah.
4 lakh, 4.5 lakh. If anyone can afford it, I think mine is a very, it's a topic which is based on statistics. So I'm more interested in talking about other people's talks, because I really liked your presentation, and thank you for showing us the surgery. That was great. And also sharing your experience with us, because once you know that this is being done, then it kinds of, emboldens you to take this step. And also we know where to go yourself for training and where to send your patients if you think that there is a center available. So I'll be talking only about the keratoplasties that we have already done. We took 400 procedures for this clinical audit, because audit, as you know, is a kind of a scientific process which has to be done in a certain manner. So we didn't take, we have done around about 465 plus. So we just took the round figure to make it easier for us. So that's why you see 400. And these 400 procedures have been performed over the past 7 years. And I'm really, really proud to say that now we have almost 5 fully trained surgeons who can perform this procedure on their own independently. And if one fine day, which will be there, I am no more there and I'm not around, I'll be happy knowing that there are people who will carry on this project. Out of these 400 patients, 65% were male, probably because the males have the financial and economic burden and they come to us more often. And the female population is somewhat neglected in that way, and they don't make the effort. Age range was quite vast, whether it's 5 to 90. Even people with 90 years of age, you'll be surprised why we are actually doing PKPs. But that's because they had only one functional eye, and in that eye, the cornea wasn't functioning. So that's the reason for this late age that you see here. I work at Bahawalpur, so all the surrounding areas. But now, since the word has spread that we are doing so much, we are carrying a large number of keratoplasties at our center, we have started getting people from almost the entire province. Because people get their names registered at, say, Al-Shifa, they also get it registered at other centers, and they come to us and they say that, and they tell us that we are registered at those places, but that you've given us a wait time of, say, like a year, and we are just kind of thinking, agar our turn comes a bit earlier, we will go to the center which comes up. All of us are getting our corneas through APNA and USA, and we are also getting our corneas from Sri Lanka as well. So we have slightly more than the rest of the province. We have slightly more share. I think we should all try and take the name of Dr. Fawaz Zafar here, the person who is entirely responsible for the entire cornea project all over Pakistan and now Afghanistan as well. I think he's sending you as well. Dr. Zarini is here from Quetta, and I'm witness to the fact that one man army is sending the corneas from American eye banks to all over Pakistan. So let's wish for more Americans to die every single day so that we get more corneas. Sri Lanka has a law actually. One fine day I asked that why is Sri Lanka sending us so many corneas? And it was, I was told that Sri Lanka has a legal structure in which they are legally bound to donate their corneas. Good law, I like that. And it is one of their major export industry. By the way, they earn a lot of money from those corneas. All of you who are probably doing these keratoplasties in your private sector, you will be familiar with the pathway. Most of them are coming from Singapore. So this is one of their industries. But when they send free corneas, for example, I get a call on Monday Let's make it interesting. Audits are so boring. Let's suppose I got a call on Monday. तो हम आपस में जोक करते हैं कि अब उन्होंने एक गन उठा लिया और श्रीलंकस के पीछे गन लेके भाग रहे हैं. जैसे ही 4 बंदे मरेंगे तो हमें 8 आंखें मिल जाएंगी. So this is what happens normally. They take a week and we get Sri Lankan corneas. Nothing against them. We are very thankful to them. I'm so happy they die and they donate their eyes and they send it to us. Oh, they send it to us. We die. We don't give our eyes to anyone. We die as well. You know, like do not donate. Sir, वो अच्छा करते हैं. So carrying on, anyone who is doing keratoplasty knows that I think the major burden of keratoplasties is corneal ulcers. We're getting a lot of that, and the resultant corneal opacities. Keratoconus is very common in our part of the world. That's because of the vernal catarrh, which is very common in where I work. And dystrophies, of course, we get families and families of that. Why are we getting so many bullous keratopathies? This is discussed in almost every conference, and that is because of the free eye camps which are being carried out right now. Even as we are talking, there's an eye camp going on. हमारे पास एक जगह है, उसका नाम है खानका शरीफ. जब खानका शरीफ, नदीम साहब बैठे हैं, is familiar with the name. जब खानका शरीफ का कैंप हो गया 2 तारीख को, तो ठीक 20 तारीख को हमारे पास वैगन भर के पेशेंट्स के आने शुरू हो जाते हैं who have either endophthalmitis or iris prolapses or any other type of complication. Think of a complication and you get that. So commonly, as I said and I've already mentioned, these are the cases for which we are carrying it out. This surgical timeline for the clinical audit was from 2018 till June 2025. All these pictures that you're seeing is from our department. These are our patients. We have operated these patients. I made a point of putting up a few. Do you see this man who has an NG tube in his eye? He met with an accident and he was in neurosurgery department for like 3 months and he recovered. When he came to me, he was on wheelchair, and by the time we did his corneal transplant, and he lost both his eyes, by the way, and when we did his transplant, now he's able to see and he's able to walk and he's very happy, one happy patient we have. How do we decide what we're going to do? Our priorities are, of course, only eye cases, then failed grafts, then pediatric patients, and we get many complex cases. And adherent leukomas, whenever you're doing adherent leukomas, you are not at all sure what you're going to end up with. Most of them have cataracts. Even if you have an ultrabiomicroscopy, you're not very sure how it's going to be, but goes well. We set our priorities, and our priorities are starting with only eye cases. We do get quite a few young females who are about to get married, and they're so concerned about their white corneas, and they think. When it comes to young females, you can disagree, but I have a soft corner for them. And I don't go for vision. Even if I know for a fact that they won't be able to see, I do give them a cornea just so that it can give them a good cosmetic appearance, because this is important. And this is something that I don't know whether it is ethical or not, but that's something that we do at our center. And we have quite a few females who are now happily married and doing well with their corneas. And Saleh is laughing, he meets them a lot. they all come for follow-ups. One thing to remember, that when they are pregnant, they do get problems with their corneas. So we do keep an eye on them, and we tell them to keep on coming up for follow-ups, and we encourage them and all during that time. We have a very meticulous data maintenance. We have a record that we are very proud of. And we have everything on record, right from the photographs to their videos to their actual demographic data, anything related to the patient. You want anything, any data, we have that, including their complication rate. We do have a registration system just like in all the other centers, and the patients have to get registered. And of course, they have to be assessed. We have to be very sure that we are not wasting corneas. As a rule and as a nation, if we get something for free, तो वो माले मुफ्त और दिले बेरहम वाली बात हो जाती है. So we do counsel our patients that each cornea costs $500 at least. So we try to give them this knowledge that this cornea that you have received, if you don't take good care of them, you will end up without sight in this particular eye. So, and also we have standard protocols for which they are called and they come up for follow-ups. Now we are going for ID documentation, because now that DP HOTA is in on this is essential and components, and everyone here who either has a keratoplasty center or are thinking of, I don't know, you don't have that Punjab HOTA authority, but here we have. The Punjabi HOTA authority has now made it compulsory that you have to tag it with their ID card numbers so that the patients can be traced and they can be checked. We have actually quite a good success rate, but then obviously with the passage of time, we all know no matter how good a corneal transplant is, you keep on losing endothelial cells, and there does come a time when it fails, and the patient, if we implant in a young patient, they would need a second transplant after like a decade or so. So you have to tell them that as well. But if you don't want to tell them, great, you don't have to burden them with this, like thought in their mind that they're going to lose their sight eventually and they were going to get another cornea. But you should be very clear in your mind that at some point in their lives, they are going to need a second cornea. Thank you so much.
Thank you, madam. I would like to request Professor Dr. Huma Kayani for a talk on future of corneal transplantation and what's next.
Oh, I heard that. I'm sad. I'm upset. My own friends telling me I'm growing old. I don't want to be old. I don't want to be old. Okay. Today we're going to talk about the future. Abhi tak aap logon ne jo kuch suna, I've talked about the corneal transplants, and I am very much interested in the future because we all know what this is always. I'm just going to skip a lot of them. The scenario, the one that you're talking about, and the one that you're thanking the West that kashkol leke nikle mein, theek hai, aur is kashkol mein hamare dala ja raha hai, and we are following and we're doing the transplants, and I'm really grateful to Fawad and really grateful to a lot of people. But is this what we're going to stick for the rest of our lives? An eye donation? We know the CT procedures, the corneal transplant is written as CT these days, so we will see CT samajhti rahi thi, but this is SOTIS for standing for corneal transplant. In सब चीज़ों के लिए corneal transplant हो रहा है, all right. But there are lots of failures. Corneal transplant, like Sophia just said, you have to tell your patient or you have to prepare your patient that you're going to have a second surgery in some time soon or later, or you don't want to tell them. All right, that's fine. But the reason for the failure will be rejection. It can be glaucoma, infection. High rejection is seen in children. So children are basically the ones that you will be telling or you will counsel their parents कि उनको redo की या retransplant की ज़रूरत पड़ेगी. ALK, DALK, you know everything about it. So we know that now keratoplasty is associated with femtoseconds. ठीक है, तो femtosecond laser assisted anterior keratoplasty is happening these days. And then there's something which is known as the duas layer. I actually had to go through the corneal. People must be knowing कि dua layer कौन सी है. This is a predestined layer which is called the duas layer. Dua है कि dua है, मुझे तो dua पसंद आया था, so I called it dua layer. So the dua layer is just underneath the descendants, and this is also now transplanted so that it gives, let's say, it enhances tissue handling, reduces endothelial cell loss. DMAC, I'm sure everybody, I'm sorry for being late, but I think DMAC ki baat ho gayi hogi, so we'll quit that. Now the CT issues, graft rejection or a delayed graft rejection. And this is usually because of the fact that by the time you get your tissue, we do not know the endothelial cell count that is written on your tissue. Is it the same one by the time you implant them or you transplant them? Because the traveling, the bank and all that, the number reduces. The number that is written on the paper might be 2 weeks old. So maybe the endothelium is even lesser by the time you do it. So that might be a reason for giving unsatisfactory long-term results. Study says that rejection is more common when after 23% of the patients see rejection on the cases, with a high risk for rejection being for the pseudophakic eyes, aphakic corneal edema, and female genders. Strange, female genders is considered कि जिनमें rejection ज़्यादा होगी. I didn't know about that. The sutures involved, those sutures involved in KPK increases the
cornea susceptibility to rejection, to ulceration, infection, vascularization, variable degrees of unpredictable stigmatism, despite the existence of various advanced switching methods. So, what are the alternatives? Challenges make the need for better graft alternatives. So, what will be looking in the future will be tissue engineering. So, tissue engineering, which will help have a better optical clarity and wound healing will be better. There will be keratoprosthetics. The ones that we have now is the Boston ones, but there are more advanced one that is coming in, which will be of biomedical materials. And then you incorporating, which is known as the allografts or the autografts or the stem cells or your tissues or the CDs, which will take, which are going to happen. I really, really hope that will happen so that we forget about actually waiting for somebody to die so that we can get a cornea, because that is really scary that you want somebody to die to get a human corneal graft. I don't want a zinda or a dead person. I want an engineered one. So the artificial corneas that are present, and boy, are they ugly looking, all of them. Look at them. So this is what we are having at the moment in banking on them. So artificial corneas or keratoprosthesis, these are medical devices made from synthetic materials, which are also called K-pros or keratoprosthesis. These aim to replace the degenerated cornea in case of multiple graft rejections for various keratoplasties. This solve the problem of immune rejections due to biocompatibility and less immunogenic materials. And there are two types, the soft ones and the hard ones. So the hard ones, these are mixture of PMMA and other hard components. They have better resistance to elevated intraocular pressure and to deformities caused by eye movements or blinking. Boston type 1 is used in the West, and I've seen a few people using Boston 1 over here also. And then there is something which is osteoodontokeratoprosthesis, which is also being used. Now, the Boston keratoplasty has two plates, one from PMA and other from PMA and titanium. And in between these two is the corneal tissue is grafted. So, and for this, need for need for artificial cornea or donated cornea is still not limited. So the soft keratoprosthesis, these are known as alpha core, which is made from polyhydroxyethyl methacrylate, and these reduce the post-operative complications like glaucoma, endophthalmitis, and stromal mills. Disadvantages, we know they are uncomfortable, they are ugly looking, they are biointegratable, non-epithelialization can occur, and post-operatively still we have glaucoma, we can have retrospective membrane formations and even anterior chamber inflammations. Now we talk about the future, the robotic, and you know the robotic surgery is present in yes, wait kar. So the importance of my apology. We sometimes forget that we're standing in a formal conference. So, era of robotic surgery. Is it used in corneal? Yes. Ophthalmology surgery requires precision and high degree of magnification. It is a study which has taken place in China. Chama say all, and they use the robot called Da Vinci 11 or Da Vinci Xi, I don't know what it's called, for a keratoplasty. In Huan Gonshin, another study, they used corneal suturing robot. Now there are robots who's going to actually suture the corneas, and can you believe that this robot did 3 types of corneal sutures, and they compared it with the humans, and robot did a fantastic job. So the humans have their errors while the robots don't. So robotic surgery is being used in DALK where they feel that, you know, that air bubble technique, the robots are better in it. So when they do that air bubble, they have less chances of perforation, and this has been already been documented and presented in corneal conferences. So future, corneal tissue in a lab. That is where we're heading. I really hope this takes off, because I still say I don't want a human cornea. I don't want anybody to die and I don't want to pray that somebody dies so that a human cornea goes. Lagta hai teri meri jaan gaya aaj karke. हाँ बन गया बस वही. So lab grown corneal tissues, we have given a go signal. फवाद साहब सबको ये भेजें. So the lab grown corneal tissues, this is what is happening now. The lab grown corneal tissues, this is a new technique, can lead to mass production of corneal grafts and end the human donated corneal shortage. This offers the possibility of customized grafts. Ideal grafts should be certain criteria. They should be tough, they should be strengthening, they should be biomimetic, they should reduce the suture application, and they should have a good functionality. Lab grown, These are cell-based, effective for epithelial endothelial regeneration. Stem cells are being used for epithelial growth. These can be autografts, allografts, the corneal stem cells or non-corneal stem cells can be used. Temperature responsive and amniotic membrane substrates investigated to obtain better cellular sheets. And I'm going to forget that. So the next big thing, the nanotechnology. These are, I feel like these are small submarines that are going inside to your DNA and breaking them and making whatever they want to. These can improve your graft survival, they reduce infection. These are hydroxyapatite nanoparticles. These help the model by reducing the inflammatory response and cell apoptosis compared to non-coated keratoplastosis. These nanoparticles technology involves using particles with the dimensions of 1 to 100 nanometers. They create materials with unique physical, chemical, and biological properties, and this technology is being used in many fields now, including eye, because it helps if you apply nanoparticles. These actually then you can actually place a magnet on the eye, and they help in movement of those nanoparticles, and rejections are reduced to markedly reduced. So these are some studies that are going on, and the 3D. The 3D printing, I would love to have something like this. Studies have focused on printing on one of the corneal layers. Epithelium bhi ban rahi hai, stroma bhi bana sakte hain, endothelium bhi. Imagine you going to a shop and getting an inkjet and so mujhe cornea bana do. Wow, that will be the day that you can just get it. So exactly, so why not? So 3D printed cornea that mimics the architectural function of a human cornea. Most used once extrusion, drop on demand, injects in laser laser technologies. Now these biomaterial materials are either synthetic and natural. And natural are usually the collagen, and collagen is being used and it's successful because cornea is collagen. So bioengineered corneas. Now this is something that I just went through and I saw, though it's not maybe hame in this part of the world kyunki ye pig ki hain, so we will have issues, but otherwise they are actually, this has been published in Nature Biotechnology. It has promising results, and मैं उसका नाम नहीं लेती इसलिए because लेकिन pig technology है, bioengineered implants as alternative to transplants. So these can be produced and they can be stored up to 2-3 years. So आप ऐसे human corneas बनाई जाए और corneas store करते जाए, and you for 2 to 3 years and they can be stored and you can use it and apply. So this is what it looks like. So bionic eyes, there was $6 million man and the $6 million woman, and now there will be $6 million bionic eye because the bionic eye will cost $6 million. So I think for that, but this is the future. Who knows? With the inflation and the problems here, the $6 million, we will say not a big deal. $6 million ka we can actually buy a bionic eye. So finally, the real voyage of discovery consists not in speaking new landscapes, but in having new eyes. Thank you.
Thank you, madam. With this, we conclude the session of keratoplasties. Thank you, everyone, for joining us.